chair the next session on mitral valve and tricuspid valve interventions. And I also would like to welcome Dr. S. Arvind, Dr. Sumant Shekhar, Dr. P.K. Sahu, Dr. Debadatta Bhattacharya, Dr. Satish Suryavamshi, Dr. Sunita Vishwanath. Sir, over to you, Sir Saibal and Samir.
Good morning,
Thank you,
everybody.
guys.
And on behalf of TCT India, I'm joined by Samir Kapadia and myself, and it's a real honor to be there with us, you guys, but from a distance. And I'll ask Samir to first engage the speakers and introduce the speakers.
Sure. So first of all, thank you, everybody, and thanks for inviting us. It is always a pleasure with working with Saibal and all the esteemed faculty. And
The best way I get to see you. So, good morning, Samir. Good morning, Dr. Radhakrishnan, and good morning, everybody in India. Oh, good afternoon. Sorry, it's good again over there in India. And it's my honor to be speaking about this topic, which has now become standard of care, about echo imaging, case selection guidance, and assessment of post-operative complications during a mitral procedure. So, transcatheter treatment option of MR is approved both in the US and India, and mitral is the only procedure which is available in India. Mitral procedure is primarily echo based, and the detailed understanding of echo is critical for the success of this procedure. Case selection, attention to detail during the procedure is therefore critical for the success of the procedure. So when we talk about imaging, the real primary modality, unlike in TAVR CT, is transthoracic echo and TEE. Transthoracic echo is primarily for the determination of etiology of MR, primary or secondary, assessment of severity of MR, and assessment of LV and RV dysfunction. TEE is to understand the morphology of MR, the procedural success, and detection of procedural complications. So I want to go to this very old slide by Nelson Schiller several years ago. But this is the foundation of some of the assessments of quantitative and semi-quantitative assessments of MR. If you look at this slide, which is a hand drawing by Dr. Nelson Schiller, he made it very simple. He started with a PISA, then he talked about the continuous wave MR jet, then he talked about the MR jet area, then he looks at the left atrial size, and finally the pulmonary vein flow. And then, of course, the TR jet, because indirectly, the TR will be more significant if you have also MMR. So what his concept was that instead of using a single parameter, if you use multiple parameters together, you can actually get a good idea of mitral regurgitation. And that's the fundamental principle, unlike in aortic stenosis, where you can use one parameter. For mitral, any regurgitation lesion, you need multiple parameters to make a diagnosis. So it's very important that when we do it, when we assess MR, before we do anything, is to make sure that you have both qualitative and quantitative measures. And this is just a list that I placed to you, which is important. And it's critical that when you're doing mitral interventions, you should not just look at a single jet like color jet. Try to look at things like ERO, regurgitation volume of fraction, pulmonary venous flow pattern, left atrial size, and then you semi-quantitatively have 3 to 4 more criteria. If you have 3 or more criteria of these that I just mentioned, then it's usually severe. So this is the other thing that I didn't mention in this slide is E velocity. Sometimes the E velocity very high usually suggests MR. So I'm just telling you that you look at it. And then finally, I just want to say one comment. Sometimes the transthoracic windows are not very good, and you often may underdiagnose MR. And in that case, sometimes the T can pick up some eccentric jets, which you missed with transthoracic echo. Now, when it comes to TEE, this is critical. It's important to understand the morphology of MR and sometimes also severity. It's very important in procedural guidance. It's the only thing. And the detection of procedural-related complications all can be encompassed by TE. So I would say that in this procedure, and Sabina, you agree with this, the role of the echocardiographer is as important as the interventionist, or even more. I mean, if you don't have a good echocardiographer doing helping in the procedure, you just cannot do this procedure. Samir, do you agree with that?
I completely agree. I think so.
Yeah, though Samir likes to do a lot of fluoroscopic imaging, but I still think TE is very important. These are some of the images. I've just given them up for you. You don't have to remember them. Four-chamber view, intercommissional, 3D end phase, short axis view, deep transgastric, and then final assessment. But to make it more easier, I'm just going to talk about a few important views. First is the transgastric view. And this is important because gives you a good idea about the orifice area, which is critical. It also gives you an idea of where the MR jet is arising from. This is usually the first view that we do. Nowadays, we tend not to use this view that much because we can use multiplanar imaging and get this view directly. So second that I want to talk about is the transeptal puncture views. And it's important to do 3 sets of views for transeptal. You can do the bicaval view, which gives you the height. You give the short axis view, which is literally 45 degrees. That gives you anterior and posterior position. And the third is the 4-chamber 0-degree view, which gives you an idea of the distance of the transeptal puncture to the valve. This is another critical view, which is the combination of a biocommissioner view and then you cross plane imaging, you get the left ventricular outflow tract view. In fact, this is the most important working view through the entire case. If you get the biocommissioner correct, you can see over here that you have P1, P2, P3, and then there's actually A2 over there. And then if you just do an X-plane through that, you get the exact position of P2 and A2. And just by drawing the line in different segments, you can get across the valve from lateral to medial, exactly perpendicular. And so this, I think, is the most important working view during the entire case. And then finally, we always try to do a 3D end face view. And in the 3D end face view, you can actually see very nicely a large prolapse segment. You make it's called the surgical view. The aorta is on the top, laterally is the appendage, posteriorly is posteriorly, and in this case, you can see a large P2 prolapse and flail. And we use this view to orient the clip to understand what the valve looks like. Now, with these in mind, I'd like to go just say a few words about case selection. When you do a case selection, it's important to do a full assessment. Etiology, severity of MR, surgical risk, the morphological criteria, and finally, which cases to avoid. When it comes to etiology cases to avoid, I actually do not want to go to the severity I just told you. Surgical risk that I actually mentioned to you, that surgical risk is important because when you are seeing a patient, you have to assess the surgical risk of the patient. If the patient is low risk for surgery and is repairable by surgery, I still think surgical repair should be option. If the patient is intermediate or high risk for surgery and his pathology is suitable, then you should consider it for a mitral clip. That's why the surgical risk is important, and it's important. Etiology is important, especially when I'm talking to people from India, because I really want you to be cautious not to consider patients with rheumatic MR. And the reason for that is that in rheumatic MR, you have a commissural fusion, and the orifice size is never completely normal. And when you put a clip in, you actually can cause significant stenosis. So you have to be very careful when you look at these MR to make sure there is no post-inflammatory rheumatic status. And then, of course, the morphological criteria we can do it both for degenerative and functional MR. And then last, my caution is, which are the cases that you should avoid? These are the ones that you should avoid. Mitral valve orifice less than 3.5 centimeters, rheumatic MR with commissural fusion, if the leaflets are calcified, if you have very severe TR which cannot be treated, you may not benefit just for treating MR, recent endocarditis, and MR due to a congenital cleft. If you have MR from a congenital cleft, then this will not really work, and it's probably not indicated. Etiology, as I just told you, these are the selection. Now, finally, a few words about the echo during the procedural guidance. I won't go in detail, but I will just say that we have, as I mentioned, the first step is the transeptal puncture. And in this view, you can see you want to be as posterior as possible to get as much as height. This is important, especially in patients in India where the left atrium is not so large. You often do not get a very large atrium. And so you should try as much to get at least 4 centimeters. Orientation of clips. This is very critical while we do this procedure, that you orient the clip correctly to the perpendicular to the line of coaptation of the leaflets. And here is an example of that we are orienting the clip exactly perpendicular to the line of coaptation, which prevents distortion of the valve. Then, of course, when we look at clips, I would like to make sure that you look at and understand the leaflet insertion. You can see over here, we've rasped the leaflets, we've got the grippers down, and you can see a very good leaflet insertion. And then you start to close the clip, and then you can get even further tightening of the clip, and now you can see that the leaflets are inserted. It's very important to record and zoom in and see this, because leaflet insertion directly predicts MR reduction and can also predict single leaflet detachment. So focus on leaflet leaflet insertion a lot. And then in the biocommissioner view, here's an example of having low threshold to put 2 clips if the orifice allows you. So here's a patient where we put 1 clip, you got a good reduction of MR, but there's still a medial jet. You accept this result, and then I put a 2nd clip, and you see we went to trace MR. So the orifice allows you should have a low threshold to put more than 1 clip. Here's the patient with 2 clips in the middle with the medial and lateral orifice. Now, assessment of post-procedural complications. There are some important procedural complications that can occur. These are some of them. Pericardial effusion, significant atrial septal defects, clip detachment, and mitral stenosis during the procedure. So we start with pericardial effusion. The first way to avoid it is to make sure your transeptal puncture is done under echo guidance. Based on the previous pictures that I showed you, if you cannot see the tenting of the septum, do not advance the needle. You must see the images that you're tenting the septum in both views, and if you can see the tenting, then only advance the needle to prevent pericardial effusion. And final step, that at the end of the procedure, it's always important to end with a 4-chamber view to make sure you haven't got a pericardial effusion. Okay. Number 2 is an ASD. This can happen during a case. And here's an example of a patient, just to show you, we'll talk about, so first I'll talk about clip detachment. Here's an example to show you that there's a leaflet detachment. And some people miss this, but as you can see over here in this picture that I showed you, that one of the clips has clearly come off. One clip is attached and the 2nd clip has come out. And in this patient, the only treatment option is sometimes if the orifice allows you, you can do another clip procedure, or you have to do surgery. And over here, you can clearly see that one leaflet is attached and the other one has come off. So you have to, this is about 2% of cases have SLDA. ASDs, on a rare occasion, you can tear the septum and cause a slit-like hole. And if the right atrial pressure is high, you can actually get a significant bidirectional shunt with desaturation. You must make sure you do this imaging during the end of the procedure. And in that case, you need to close the ASD. So I'd like to summarize by saying, before I summarize, I'd like to say that single leaflet detachment is the commonest serious complication that I'm worried about always. And it is very critical, therefore, to prevent it rather than just detect it. But you should look at it. Single leaflet detachment usually occur in the first 24 hours, or usually during the procedure, and most of them will within the first 30 days. That's why it is very critical that when you do procedures in mitral clip, that the 30-day echo must be done in your own hospital to make sure that usually after beyond 30 days, it doesn't occur. Right, Samir, do you agree with that, Samir?
Yeah, I agree. I had one 94-year-old patient that came 6 years after, but maybe
I see. Oh, wow.
I know, but like he was doing some crazy exercise, and then he felt short of breath. Maybe
Oh,
the
wow.
leaflet around it was so messed up that it just expanded. But I completely agree. Very, very rare. I was just looking at the TEE right now to try to
Yeah.
understand why this happened. But I
Why this
agree. I've
happened?
not seen it at all before.
Yeah, in most cases, this may be tissue degeneration with the older patient, but usually it is usually in the first 1 month. And then, of course, effusion is important. And then mitral stenosis, you can always prevent it by then measuring the gradient after each clip detachment. So you attach the clip and you measure the gradient. And if the gradient is not too high, then you can deploy the clip. So be careful before, because once you deploy it, then it's no coming back. So I would like to summary that imaging is critical before, during, and after the clip procedure. There's a role for both transthoracic and transesophageal echo. Case selection is critical, and image guidance is important to prevent and detect these complications. Thank you very much.